Okay, we're recording. And so we're going to go ahead and just jump right in. We have Dr. Elisha Wachman with us today for our journal club who's going to present. Please feel free to put questions in the chat during the presentation, and we will have a moderated Q&A at the end of her presentation today. And we look forward to having a discussion at the end and also to your presentation. So I'll hand things over to Elisha to share her screen and introduce herself and get going.
All right. All right. So it is so great to be here and to see some familiar faces of folks I haven't connected with in a while. So thank you, Caitlin, for this opportunity to discuss a topic that I've thought a lot about recently, and wanted to share, some preliminary thoughts, and then would really love a discussion about this. But just a background for those that I don't know, I'm Elisha Wachman. I'm a professor of pediatrics at Boston University School of Medicine. I'm an attending neonatologist at Boston Medical Center and researcher. Most of my work centers around opioid use disorder and pregnancy and neonatal opioid withdrawal syndrome. All right. So I'm going to just do a brief background for those of you that don't think about NOWs all day long like me, just about, I could just clarifying some definitions, some of the factors that we know are associated with differences in outcomes, and then really focusing on fentanyl use and what we know so far about how this has affected now severity, sharing an initial report that was published about a year or two ago, and then again our more recent manuscript from Boston Medical Center will be the core of the discussion. And overall, the goals are to understand the known factors associated with now severity and to understand the association between fentanyl exposure and now severity. But taking a step back again, just to some definitions to ground all of us. So I just wanted to share with you a couple of consensus definitions. So when I talk about neonatal opioid withdrawal, I'm talking about infants that have an in utero exposure to opiates with or without other substances. So as we know, many of them are polysubstance exposed, and this can be by maternal self-report or by toxicology testing. And the infant also has to have clinical signs of withdrawal. And so you can see there the possible signs, and this was sort of agreed upon for or the definition that we're talking about today. And just important to note, it is not dependent on need for pharmacotherapy. And I don't have to tell this group, but just a quick reminder that, now it's sort of increased significantly over the past decade, that we've seen maybe a little bit of slowing down in more recent years. And again, there's been this difference between the rural and the metropolitan areas, which I think all of you are aware of. So clinical presentation, really I'll go over in a little bit more detail, but it tends to be in general buckets, central nervous system disturbance, gastrointestinal, respiratory, autonomic disturbance that typically shows up 2 to 3 days after delivery for long-acting opiates, but for short-acting such as fentanyl, this can occur earlier, within 0 to 2 days after delivery, after the cessation of the exposure from the placenta. And there's, a number of different ways that we use to assess now. So again, I see Loretta is on. So this has been our standard since the 1970s of sort of looking at, ways to assess infants with withdrawal. Is still utilized by many hospitals across the country. The other approach, which is commonly used too, is the more function-based assessment of eat, sleep, console, which has become, more common over the past decade as well. And again, there is not one consensus as to what hospitals are using. There's still significant variation that we see across hospitals, which again makes things very challenging for research in this area, as you'll see as I get into the papers. Just sharing here with the study, the most recent study that was done comparing the two did show a slight advantage for those with the ESC approach, but again, there's still significant practice variation that exists. And I think the core for anything is that non-pharm care has been established as the primary treatment for neonatal opiate withdrawal. And I've just listed some of the components here, but this is really considered to be first line, no matter what assessment method you are using. And then for pharmacologic treatment, there's also a lot of variability that you'll see. So in general, it is thought that you should start with an opiate medication. So the most common used in the US is morphine, followed by methadone, then buprenorphine. But again, you'll see a lot of variation. And second line therapy being clonidine or phenobarbital. The other thing just to mention, which again also makes doing research in this area more challenging, is there's been this shift in recent years in how we dose opiates for nows, and just to this more symptom-triggered or PRN approach. And again, sorry for the typo there at the top. So again, a lot of centers have switched to this more symptom-triggered dosing. There's an ongoing NIH trial. The Optimized Now trial was just looking at this approach to now's pharmacotherapy. However, there's some consensus in terms of outcome measures that people should be looking at in research. And this was, again, recently published. And so I think the most common I have highlighted there in red is that people tend to look at markers of pharmacologic treatment as a marker of now severity. So looking at whether or not they require pharmacotherapy, if they require one or two medications, what is the duration of treatment, and then length of stay, like length of hospital stay tends to be a common marker. I mean, other outcomes are looking at things like feeding difficulties, looking at breastfeeding rates, weight gain, readmission are also common outcome measures. And I put a note there on the bottom is that some studies have also done sort of adjusted length of stay due to neonatal opiate withdrawal, because sometimes infants are in the hospital for other reasons, such as prematurity, that are not necessarily due to the treatment of their withdrawal. And so analysis is incredibly variable. If you look across different studies and different hospitals, you'll see a lot of variability in pharmacologic treatment rate, but it tends to be, I would say in general, around 40 to 60%. But I think many of us know when taking care of these kids that there's a subset that has very severe withdrawal that, requires like sort of multi-drug regimen, but there's significant variability, and this is very multifactorial. We know a lot of the factors that influence this, and some of it is some of the things I mentioned is that we use different assessment tools. We have different hospital care models if the kids are, taken care of in a rooming in model versus not. But just talking about some of the maternal exposures that we know about, we know things like psychiatric medications, polypharmacy can make a difference, which opiate they're exposed to, it's thinking about methadone versus buprenorphine. But what I'm going to focus on today is thinking about the non-prescribed drugs and specifically fentanyl and NALS. And so that's going to be really something that I started hearing from a lot of hospitals in Massachusetts, I don't know, maybe 4 or 5 years ago. And certainly from the clinicians at my hospital that they were coming to me saying, like, what is going on, with these babies? This is not what we've seen in the past. And really commenting on the fact that they were having very severe withdrawal and specifically a lot of feeding challenges that seemed sort of more than usual. And so just to start off, we know there's been this huge increase in prenatal fentanyl exposure. So just highlighting a couple of recent papers. One was from our group at BMC. The other is from the MatLink Collaborative, which I know some of you might be part of, showing this huge increase in fentanyl exposure, now up to 60% of individuals with opioid use disorder. That includes people that are also on MOUD, which is certainly the case at Boston Medical Center. Is the vast majority are also on MOUD, but still have fentanyl co-exposure. And so I think also just to note here is that there's been a fetal fentanyl syndrome that's been described, which has some characteristic physical characteristics as well as biochemical, where there's been alterations linked with the cholesterol metabolism pathway. Again, this is an area that I know our group is sort of thinking about and trying to research, as well as many others, and trying to understand why this is happening. But this has been described with prenatal fentanyl exposure as well. So in terms of thinking about why might fentanyl exposure cause severe NALS, I think there's a lot of reasons that, are sort of intuitive. It's 100 times more potent than morphine, 50 times more potent than heroin. It readily crosses the placenta. I think it's like 85 to 90%. And it rapidly crosses the blood-brain barrier. And so it could therefore, affect the developing brain. And there's been studies that have been done, preclinical models, animal studies showing that it does impact, neural development. And we also know, I work in the NICU. We sometimes have to give babies fentanyl for sedation, critical illness, and that has been associated with, risk for things like cerebellar injury. So it sort of makes sense that there could be this potential effect of people that are, exposed to fentanyl throughout the pregnancy. The other thing which I've been thinking a lot about and would love impact from this group is adulterants. And so in Massachusetts, the vast majority of our fentanyl also contains adulterants such as xylazine. Again, this is not included as part of routine toxicology testing yet. And this is a really potent sedative, muscle relaxant. And there's been case reports that this can cause, some symptoms within the infant of significant inconsolability and irritability and feeding difficulties. It's known in adults that are exposed to fentanyl, as well as xylazine, that they have more severe withdrawal, and there's a potential role for using alpha-2 receptor agonists in treatment. So again, something I've been thinking a lot about as well. So I just wanted to share, this was the first article I mentioned that was published last year. I don't know if anyone from this group is on, but this was the first paper that at least I am aware of that focused on fentanyl and the risk for more significant neonatal opiate withdrawal. And this was a study from one NICU in Tennessee, where they had universal screening and toxicology testing by both urine as well as infant cord blood or cord tissue. And they did have, again, record of whether they were on MOUD. Their infants were treated in the NICU setting for NOWS management using modified Finnegan scoring. And their diagnosis, or their criteria for having a diagnosis of severe NOWS, was whether or not the infant received pharmacologic treatment. They utilized scheduled morphine for pharmacologic treatment, and phenobarbital was their secondary agent for those infants that had more severe withdrawal. Their primary outcome measure was NOWS requiring pharmacotherapy. They also looked at fentanyl levels within the cord tissue, as well as how much morphine the infants needed for NOWS treatment. And you can see there, they were primarily comparing the fentanyl versus non-fentanyl groups, and they did some regression analysis adjusting for a number of covariates. So I'm just going to highlight their results here. Again, I tried to highlight in red those that met statistical significance. So there was a slight difference in maternal age. You could see more patients in the fentanyl negative group received prenatal care. And there was also a higher rate of hepatitis C exposure in the fentanyl cohort. And you can see here in terms of what other substances they were exposed to, there was a much higher rate of polysubstance use in the fentanyl group, and overall, higher rates of each individual exposure. But again, 99% were polysubstance exposed. There was a much lower rate of MOUD in this cohort, overall about a third. And you can see there at the bottom the breakdown of methadone versus buprenorphine. And so what they found, not surprisingly, was that the fentanyl-exposed infants had a longer length of stay by about 10 days. They were much more likely to require pharmacologic treatment and to require 2 medications for withdrawal, and also less likely to be discharged home with birth parent. The other interesting thing that they found too, they did a little bit of a breakdown by gestational age. And so actually there was a more significant difference in the full-term babies as opposed to the preterm, which we know we've seen that before in terms of like how preterm babies experience withdrawal. They also saw a correlation with the umbilical cord fentanyl concentrations and the amount of morphine the babies required. So there seemed to be some dose response relationship there as well. So again, these are kind of their final results. So unadjusted, that there was a significantly higher incidence of severe NOWs requiring pharmacotherapy. Infants were also started on treatment earlier. And again, their regression analysis, you can see there was almost a threefold increased risk of requiring NOWs pharmacotherapy, and they had a longer length of stay. Again, it was 40% increase in the preterm and 63% increase in the full-term babies. So that takes me to, again, the publication that I wanted to highlight. This was done by first author Bailey Cooper, who is now a first-year NICU fellow at CHOP. Maybe some of you know her. She's amazing, but she did this project with me last year when she was a resident at Boston Children's and Boston Medical Center, looking at our cohort of infants with prenatal fentanyl exposure. So we looked at our data from Boston Medical Center between 2017 and 2024. These were all in utero opiate exposed infants monitored for NOWs. We do universal verbal screening for substance use disorders and toxicology testing for those with known substance use disorder in pregnancy. We do quantitative urine fentanyl and norfentanyl levels throughout the pregnancy and on labor and delivery. And again, the majority, I think, different from the last study. The vast majority of our patients are on MOUD throughout the pregnancy. Our NOWs protocol is quite different from the last study. We have rooming in on postpartum and pediatrics, so they really shouldn't be going to the NICU unless there's another medical condition. We've been using the ESC care tool, and we use a symptom-triggered methadone dosing protocol and phenobarb or clonidine as adjunctive treatment. So we compared the fentanyl exposed and non-exposed groups, and then we did a subgroup analysis within our fentanyl cohort to look at the timing of exposure. So, whether or not there was exposure that we were aware of in the month prior to delivery versus prior exposure earlier in the pregnancy. And the outcome measures that we looked at were pharmacologic treatment, number of opiate treatment days, length of stay, whether they needed an adjunctive medication treatment, as well as we looked at NOWs feeding measure of whether or not they required a nasogastric tube for not meeting standard oral feeding volumes per our hospital guidelines. And again, conducted regression analysis looking at relevant covariates. So I'm going to highlight our results here. And so you can see here, just as expected, is that there was a drastic increase, as time went on in the percentage of infants that were fentanyl exposed. And I think notably too, the majority of them also had exposure. If it was early in the pregnancy, still 75% by the time of delivery. And there were otherwise no differences in our racial or ethnic grounds of our mothers in the study. And looking at exposures, there were significant differences. And so you can see here, overall, there was a higher percentage of methadone for MOUD in the fentanyl cohort. And then similar to the last study, we saw a lot of other co-exposures in this group, cocaine, like all of the psychiatric medications were a lot more common in the fentanyl cohort compared to the no fentanyl exposure group. And then for our infant results, you can see that, overall, thinking about the NOWs outcomes, there was obviously a much lower rate of breastfeeding in this cohort. NICU admission was higher, and overall length of stay, need for medication treatment, opiate treatment days were significantly higher in the fentanyl group. They were more likely to go on to need scheduled methadone, to require a second medication. And you can see a significant difference also. They were almost, 25 versus 40%, more likely to require a feeding tube placement. We also saw a slight difference in gestational age, but you can see also birth weight was notably lower in the fentanyl exposed group as well. And I think one of the things we looked at, as I mentioned, was looking at the timing of the last exposure per toxicology testing. And we did see differences where those that had exposure that we are aware of in the month prior to delivery were more likely to deliver an earlier gestational age with lower birth weight, more likely than to have NICU admission with longer length of stay. But notably, we didn't see significant differences overall with the NOWs outcomes based on timing of last known exposure. One thing, this is a paper we're working on now within one of my other trainees, is we've been trying to take a deeper dive into looking at concentration, since we do have pretty detailed concentration data from across the pregnancy, across multiple time points. And we do see, similar to the last study, sort of a dose relationship where those babies that were exposed to higher mean concentrations across the pregnancy and higher concentrations at the time of delivery. Again, this is based on urine testing. We're more likely to require pharmacotherapy and to need a second agent as well. So these are sort of our final adjusted results here, which again, you can see overall, if you look all the way to the right there, length of stay was about 5 days longer in those in our adjusted analyses with any fentanyl exposure. And there was about, again, a twofold increase, similar to the last study, risk for pharmacologic treatment with fentanyl exposure. So I put, sort of my thoughts on strengths and limitations. So it was, again, one of the first studies to look at the effects of NOW severity in a large cohort of infants, that we looked at a range of outcomes and had pretty detailed covariate data available. Limitations, obviously, like we're not able to look at, adulterants and urine toxicology. These were primarily babies co-exposed to MOUD. So we were not able to look at a fentanyl alone group, which is a limitation, which I think the prior study was able to had more infants in that cohort. There's obviously a lot of unmeasured confounding in the fact this is a retrospective study. And again, we really didn't look at, as I mentioned, any signs of sort of congenital anomalies or other outcomes related to fetal fentanyl syndrome. So I think my big questions, and I would love questions from the chat, but I have been thinking about some of these. One is looking at these two studies. That's they use different NOWS protocols and treatment algorithms. However, I guess still found the same findings, which I think is interesting. This co-exposures and polysubstance makes this a really difficult question to look at. But I think the third point that I've been thinking about is, like, should we be treating these kids differently? Because clearly they're acting differently. And I'm curious if anyone has altered their treatment protocols as a result. So I will pause there, and we can take questions or discussions. Let's see. Yeah, Caitlin, you let me know what you'd like to do.
Yes, thank you so much, Lisha. That was great. So yes, please feel free to put questions in the chat or raise your little Zoom hand, and then we'll call on you. So it looks like we do have we have one person put their hand raised. Nika, am I saying that correctly?
Yeah, thanks, Caitlin. Elisha, I cannot thank you enough for doing this study. We have been wondering, are we harming people? What are we doing wrong? Why are all our babies getting NG tubes? It's been a deep, deep, deep soul searching adventure.
Yeah.
As you know, I'm an OBGYN, so I feel very out of my league when talking about nows, and just seeing our families suffer for these really long NICU stays. So I just want to really appreciate you for doing and looking into this, and leaning into what clinicians have been saying, like you said, for years. My question is, you went really fast. I was trying to take pictures of slides. But I wanted to know, actually, it looks like Camille just put in the chat the question that I wanted to ask. One piece I would love to do as a prenatal provider is learn about how we should use these data to change our counseling of pregnant folks in terms of anticipation of how long their baby is going to be admitted, what proportion are going to be getting treatment, because that feels very different from the older data that we've been using. So I was wondering if we could go back to your study's findings and the prior study's findings and just talk as a group about how we might modify that counseling. And again, thank you again.
No, that's a really good thought, because, based on all of this, they are more likely to require pharmacotherapy, and it's more likely that they may end up needing a feeding tube. I guess with us, it's almost half of them are requiring feeding tubes. I mean, I think one thing that's interesting, and I think why I'm interested in looking at this kind of timing and the dose response is could this be used in early counseling to say, lower exposures across the pregnancy, and not closer to the time of delivery, could we have more data to show that, motivation to say, yes, you're using, maybe in the first trimester, but, as time goes on, we show that can have an impact on, lower need for pharmacotherapy. So maybe that would be a potential, other factor, just to say that, we have, like, we're working on, like, sort of getting that piece out there, just to show that there does seem to be some dose relationship and some link with timing of exposure, which I think makes sense. But I do think you should counsel more that they are significantly more likely to require pharmacotherapy and to be in the hospital longer. And I don't fully understand.
You're looking at in like the last month. That's also like a very, I feel like, clinically relevant and easy to discuss piece. I think the other piece I'll just throw in is a lot of our patients really expect they will go to term, and we spend a lot of time talking about how you really shouldn't assume that. And so when we're talking about the month before birth, we need to adjust that, given that these babies are smaller. Preterm birth is really common for a whole different level of structural factors. And so when you're talking about a month before birth, we really need to be talking about like 32 weeks, 30 weeks, et cetera. Anyways, thank you.
That's a good point. No, that's true. Yes. Let me see if there's something in the chat here.
Looks like Loretta is raising her hand.
Yes. Loretta, how are you?
You're muted, Loretta.
Yes.
Can you hear me now?
Yes, we can hear you.
Thank you, Elisha, for this excellent study. I wondered whether you did any sucking studies in babies who were exposed to fentanyl. And because we did a number of those, and with babies exposed to methadone, heroin, and their sucking was really very, very poor. And I wondered whether with fentanyl it's even poorer, and that this limits their ability to feed orally.
Yes. So we have not done any formal studies. I mean, they're all seen by our occupational and sometimes our speech therapists. So I would love to learn more about how you sort of objectively studied that, because, right now we're just sort of looking at what the opinion is of the folks that are working with them at the bedside. But I do think there's something there, because I think what the bedside providers are telling me, that it's sort of like they're over the peak of withdrawal and they still can't feed. And so it's not that sort of, what you see in acute withdrawal, but like even after they're, a week off of methadone, they just can't, get to the point where they coordinate the feed. So I would be really interested to think about how to more objectively study that, because I think that's one of the primary reasons that we've had kids, go on to like feeding rehab, because they, they're over the opiate wean part of it, but they just can't go home yet. Yeah.
Well, maybe we can have a chat, offline, and I can send you the papers that we did. And, there was a special apparatus that we had.
Yeah.
So, but that might be interesting to see whether, it is directly related to the sucking reflex. In other words, the amount of sucks per minute that the baby could do when exposed to methadone and heroin was markedly reduced in contrast to the normal child, where there are 40 to 50 sucks per minute. I mean, the exposed babies were down to about 20.
Yeah, that's really interesting. Anya.
Yes, Elisha, let me just give you lots of hearts, okay? For this wonderful presentation, for engaging us. I see most of the, just the colleagues and the choices and the WAG folks joining. I think that it is very important for all of us to recognize the impact of stigma and also the importance of education. And partially the data that we see is that patients are much older and present to treatment much later in their gestational age, or they come during delivery without any prenatal care. And as you pointed out, based on your research, which all of us, I believe, see, is that we have a lot of adulterants and a lot of polysubstance use, which makes a very big difference. I do hope that we as a group discuss the importance of how we counsel our patients, how we educate them to be able to improve the stigma and to allow for patients to trust us to engage in treatment much earlier. And related to newborns who are exposed to in utero fentanyl, I personally see a big difference for babies who were immediately exposed before delivery. And my advocacy is how we counsel the parents and how we try to work on feeding to make sure that we, just allow babies to have a better chance to feed better during the first few days, which usually could be Elisha and team with offering higher kcal, donor breast milk, and how we counsel and what kind of nutrition, OT, a pediatric family medicine, OB/GYN counseling we offer, in addition to focusing on treating the birthing parent. I wonder how many people who are attending today would be willing for all of us maybe to think of a 6-month chart review, which will be a multi-system review to think of newborn maternal outcomes and get a little bit better data that will allow all of us to learn from our experience. Thank you.
Thank you so much, Maria. Lots of good thoughts. No, I totally agree with that, and thinking like, how are we actually supporting the feeding? How are we counseling the parents? And like you said, both of these studies, and we have certainly seen it, that they're presenting often at delivery, right? So, and without that engagement, which is a change, from before. I know there's a lot, Caitlin, in the chat. I don't know if there's anything.
I can help you with that. So there's kind of like 2 buckets of things in the chat, and just speaking about your data. One is about testing for adulterants, kind of like what Vanya was just pointing at, and if that was done in your study and how that impacted any results, if possible.
Yeah. So from my knowledge, again, I've done some researching of this for my research. Like, I don't believe that it's currently commercially available to test for xylazine, from my understanding. So we did not test for that. At least, like, I know there's ways you can test for it from, like, a research standpoint, I think, which is something that we are looking into. You can do cord tissue, testing to look to see if there's xylazine exposure. But we, at our hospital, certainly to my knowledge, it's not commercially available, though I would love for somebody to tell me, that have implemented this, but that's not something that I am aware of that I've seen in Massachusetts.
Mm-hmm. And then a related question was about fentanyl testing in particular. We've been talking about it, but not every institution has that on their routine drug testing, with whatever version of toxicology testing they're doing. Any thoughts that you've had while mulling over this data and this topic on the maternal and newborn side regarding fentanyl testing when it's warranted?
Yeah, no, that's a whole nother talk. It's because many people, as you know, are moving away from doing any toxicology testing and relying more on verbal screening and asking about that, which is, again, I'm not, either approach I think is appropriate in whatever setting. I think we have relied on, some of the more recent research that's been published, which says, yes, universal screening for all. And we do, if known substance use disorder this pregnancy, we do written informed consent and are sending the toxicology testing to help us inform sort of our clinical management. But again, we know that there's variations in that. And I think there's certainly ways to look at this through verbal report, and that would still, give you the information. And I see Jess Gray, who I know MGH has taken similar approach, might be able to comment more on that. So, yeah.
Yeah, Thanks so much, Elisha. Everything you do in your research is just so impactful. And I'm so glad that you, echoing everyone else, I'm really so glad that you have really dedicated so much effort to thinking through these pieces. We do have xylazine testing at MGH, so we can request it. It's just, a special request. What Elisha and I have been talking about in the past, which I think is a real need, is thinking about how we incorporate drug sample checking, like drug checking in these conversations and in this this area, because I think there's a real disconnect between sort of what patients are using, what maybe their addiction or obstetricians understand about what's in their drug supply, how that then translates to the birthing hospitalization, the pediatrician who takes over and has even less information, right, about sort of what these kiddos may be exposed to. And we have this point of care real-time drug checking, right, where patients can actually find out in real great detail, immediately sort of some of the pieces, but then, within a couple days to a week, right, like really what are all the various adulterants in there. And so they are so far ahead of clinical medicine in terms of really, teaching us what's in the drug supply. And so how do we then, in a very patient-centered way, I think that's part of the hard part, take something that is really outside of the healthcare system and use it as a tool to support the care that we provide without bringing all of the stigma, all of the risks that come with sort of identifying these pieces. And so, yeah, I think it's a really wonderful area to sort of triangulate somehow. In terms of how we identify, because again, xylazine's actually going down in our area, and medetomidines like popping up in certain parts of our state, right? And there's just so many adulterants. If you look at Tracy Green's work and Street Check, and so, I think as we're learning so much about fentanyl, right? The fentanyl analogs are changing, and now we have these like novel orphines coming into the drug supply, which already been picked up in in our toxicology testing. And so it feels like the Wild West. I think it really does feel like somehow the drug checking is that linkage that would allow us to have more information.
Yeah, no, I love that. I'm not sure I have the brilliant solution for how you could then incorporate that, but I think it would have to just come with, especially, your program drafts or, programs where you have this established relationship that people feel comfortable sort of doing that and sharing that with the clinical team that could lead to like tailored counseling, right? But
And then Josh brought up a good comment in the chat, I think, about non-pharmacologic strategies for these infants, and how these two patient populations, so much, is on the focus on the family, which is so great, and the mom, and thinking about if you're using the variable and identifying them as recent fentanyl exposure, that a lot of times can be a proxy for being, unstable in treatment, new to treatment, et cetera, and that social support and kind of, the chaos that's happening in that aspect of their recovery trajectory. How do you think the differences between potential non-pharm strategies that these families are implementing for these infants might have influenced your outcomes?
Yeah, that's a really good point, because I think, one thing I don't have here, but you can see, breastfeeding, we have shown a strong association between breastfeeding and parental presence, right? Like directly correlated with the amount of time that the parent spends at the bedside, just sort of like one marker of non-pharmacologic care. Because otherwise, each institution presumably is giving each baby the same non-pharmacologic care, like options, right, in terms of whether they're in the NICU or else. So I think that there's significant unmeasured differences in non-pharm care, that the fentanyl group likely does not have a parent at the bedside as frequently. We do have volunteer cuddlers. They're not there 24/7. So I think that's likely a significant factor, but it's something that's often very difficult to measure. So we often use things like such as location of care and breastfeeding as sort of proxies for this. But in the past, we've measured parental presence as, kind of like a vital sign that we measure every 4 hours. So that's another thing we could consider doing, is like measuring, the presence of a caregiver at the bedside. But I do think that you would see significant differences between the cohorts for the reasons that you've mentioned. Yeah.
Alicia, can I ask a question about that as a variable?
Yeah.
Because I have to say, I use that work that you've done on parents coming to the bedside all the time to help patients and think about how important they are as part of the treatment. And I just wanted to another shout out to you. I love that study so much. Are you or is anybody's NICU kind of routinely capturing that in their medical record in a
Yeah.
way that is, and I'll just say non-stigmatizing? We have gone back and forth with our NICU teams about kind of charting that is promoting positive behavior and is supportive rather than like parent wasn't there, parent wasn't there, parent wasn't there, which can feel really terrible when people look at their medical records. So I was curious, A, if it's a standardized piece that's there all the time, in which case maybe you could even incorporate it into your upcoming study. And B, I'm just curious about other people's ways of getting that into a medical record that's not A, labor intensive, and B, harmful to the family.
Yeah, so at our institution, it's part of the ESC care tool. So it's documented as part of a flow sheet that's an EPIC as part of the care tool. So every time they're going in to assess, there's sort of a assessment of like all non-pharmacologic measures. So it's not only that, but they're looking at all of these things and sort of putting suggestions for what we can do, to optimize. But it's included as part of that sort of routine assessment that's there, but not as sort of like a standalone highlight. Parent is not there, but just as part of the flow sheet, which I would think the parents probably, I'm not sure that would be something that would be available, say in my chart, which would be to look at like the details of like the ESC flow sheet. And I guess just to note on that, that is relatively standard also in our NICU to document whether or not there was like family presence, and maybe kind of normalizing it just to say that any child that's hospitalized, we kind of want to know, that we were able to update the family that they're here, sort of framing it in that standpoint, that's like, at least in our unit, that's something that we look to do every day and not necessarily just for this population. But I think the way that we document it again is that's part of the ESC care tool. Yeah. All right.
Any other questions that people, I think I summarized the questions in the chat. So if I missed your question, if I interpreted it wrong, please speak up and let me know. I didn't want people to think that I'm ignoring their questions.
Yeah. I think we've gone over this. I was going to say before I end, I just definitely wanted to thank my Caitlin, you and the whole WAG group and the collaborators on this project, which again, I didn't mention all of them, but Kelly Saya, obviously from Boston Medical Center, again, Bailey, who is the first author, Melissa Blake, who's the other trainee who's been working on the dose response, and then Soraya is our data analyst. And then we have some funding from the CDC MatLink project and Department of Pediatrics.
Alicia, can I ask one more question since I don't want to take other people's, nobody else's hand is raised. I was wondering if kind of going back to your intro, if you think that this is kind of the mild form of a spectrum of like is connected to those more severe forms of fentanyl exposure syndrome versus you think this is something completely separate. Just I know you can't have a space answer. I'm just curious about that.
And just of note for people like we have a couple of grants living in NIH land, and maybe one day might be a review thinking about this. I've done a lot of readings sort of thinking about what this could be. And so just so for folks know, so the fetal fentanyl syndrome is thought to be related to abnormalities where fentanyl is thought to impact cholesterol transport. And so there's like an overall deficiency in the amount of cholesterol that the infant sees early on, which is like a known to impact thing like, fetal development. And so some of the characteristics are, one is poor feeding is like a really common manifestation of, it's very similar to, if those of you in the NICU, the SLOS, which is a genetic mutation, which causes problems with cholesterol metabolism. so some of the manifestations, again, are poor feeding, and then again, a lot of neurologic abnormalities, which are seen where they have developmental delays and things like that. But so I wonder, if part of this could be related to, again, cholesterol deficits. But again, that's something in my mind that potentially could be modifiable, because what is seen in, like, again, the couple of case reports that have been published is that you have elevations and certain markers of cholesterol, deficiency essentially at birth, but that this gets better after like 2 or 3 months. So it's not, versus the genetic condition where it's like forever. So could you modify something, early in pregnancy, to affect that piece? So yeah, I wonder if that's part of it. The other part of it, I think, is, as I mentioned before, is that I think there's significant placental transfer, and that they're seeing a lot at the blood-brain barrier, and that it's affecting, I think that's more what the preclinical studies have shown, is that this, I think, is affecting sort of brain development early on. Is probably more of a contributor, but yeah. And the adulterants, the multifactorial, many things. Yeah.
Sorry, I'm going to raise my hand and jump in here. Thank you also for all of this research, and this is great. And I love seeing all my attendings over the years here. This is great. I guess I am curious about how people are counseling patients on the fentanyl exposure, because I sort of was like not sure about if that was like there's like a cluster in one area. I can't say that I'm super deep on all of the research because I think what we've always counseled patients is that opioids are not teratogenic. And so does this change what we tell people in terms of how there might be risks for their children? And I think also, I'm in Miami, and Trisha and Nika know that I have a pregnancy clinic here for people who are using drugs at University of Miami, but I'm happy to participate in the study. We have like small number compared to where I've lived before in Boston and San Francisco, but I would be happy to try to participate into a multi-center study, because I really wasn't sure how to integrate the findings from that paper, if that was really real. But it's yeah.
Yeah, I guess I would defer to others, to the group who are not neonatologists, on how they've been counseling their patients in pregnancy about this. But I agree, like having something larger would be great. There are a couple of national clubs, like, MatLink is one of them, that I think there's like 13 or 14 sites that are collecting data that might be able to look at some of this. But I would love for this group to think about how we can expand on this, because as you can see, it's so complicated. There's so many factors involved, so it's really hard for a single center to like make any definitive conclusions.
Yes, thanks, Katrina. I think that the next step for all of us as a group would be to create a multi-center chart review where we only for 6 months period, okay? We don't need a very big sample. At the same time, learning from each system will allow us to find the better ways to counsel our patients. As a clinician, I usually stress on education and offering information to our patients, letting them know the importance of breastfeeding, of choices, of what is available, of nutrition counseling, OT counseling, bonding, skin to skin, donor milk, 72-hour breastfeeding is something that we have implemented. And I find that it does make a big difference. The most important difference is that we break stigma. And we allow patients to trust us, to create this space of safety and comfort where they feel that they are seen and they feel that we are one team and we are there for their babies, and allow them to grow as parents, to learn. And to me, this is a very big factor. Okay. And I hope that we as a group decide, it could be 3 or 4 systems. Okay. And if anyone can make a difference to learn learn from our experiences and to advocate for our patients, it is us, it is this group. So thank you for your consideration. Katrina, I hope that's helpful.
Yes, and I'm happy to send to, Caitlin, maybe to distribute kind of what variables we collected in our database, like our red cap kind of form. If folks want to think about that, we'd have to figure out how to do that, but I'm happy to send kind of like how we collected our data at BMC. But
it would be great if we could get anonymous drug testing, like
yeah,
as a part of this.
Yeah.
Yeah, just to say about the drug testing, I mean, I don't know if everybody's done it from the street lab, but they send you a kit and people can, once you put the drugs in the kit, there's some chemical that activates it so that it's not illegal to send the kits through the mail to UNC. So it's like Jess was saying, it's not immediate, but I don't know. I maybe a starting point is to ask our patients if they would be willing to use the kits. And I don't know if there's somewhere in Boston where they have an LCMS machine where people can just go and get the results more quickly. But I think you guys have more stuff than we have in Miami. But I don't know.
Looking at the chat here. Yeah.
And Elisha, kind of as we're starting to wrap up, the last few questions are kind of going off of what Katrina was saying, a little bit more about our counseling, kind of from the
Yeah.
And I know this is not what your study exactly was on, right? Because of the fetal fentanyl
No.
syndrome and all that.
Right.
But I know I know you said like I'm the neonatologist, but you see these babies, and follow them like later on. We're, and I speaking for the OBs, a lot of times we're more on the front end. So I guess that the two last things to kind of cover from the chat conversations is anything more that you would say I wish my families were getting more counseling in this point earlier on. Anything that you would say as a neonatologist. And then the other point is kind of like big picture from a policy perspective, right? An advocacy perspective. Any last thoughts that you have?
Yeah, I guess from a counseling perspective, my impression is that families, especially because most of our families are on MOUD, that they don't understand what the continued fentanyl co-exposure does in terms of risk for nows. And I have wished, that there was more anticipatory guidance about that earlier on. So it's not a surprise when their baby is here much longer than they anticipated the baby would be here, especially if maybe they had a prior child, years ago, or maybe that wasn't the case. And so I think just letting them know, even though, there's a lot unknown that we've noticed that they might be here a little bit longer, doesn't change the fact that they can be still highly engaged and roomy and do all the same things, but the baby might, require additional support. Policy too. I mean, I guess my thoughts too are kind of along the lines of what everyone's been talking about with the testing and doing more advocacy for that, because that really seems to be an area where we just don't know, more. And so why the fact that people don't automatically have some of this available, clinically, I think makes it challenging for us to fully understand and counsel patients. So that would be an area I think we could all sort of advocate for.
Thank you so much for those last thoughts. I know we're having a great discussion, but we are at time. So I'm going to encourage everyone who's here. I'm going to send out, as usual, I always send out the link to the recording onto the Choices listserv. So please feel free to empower yourselves to, reply all to when I send out that email and we can continue some discussion, over email with the larger group too on some of these topics and working towards some goals that we can have too from a work product perspective, because I know we're all inspired to just figure out how we can all do a better job for the families that we care for. And I, as the research person, like love the fact that we're like using a data-driven approach to do this, right? Like we're looking at data as real time as we can and really just trying to, and we aren't waiting until we figure it all out, right? Which can take years. We're figuring out right now, like how can we bring this back to our patients now while still trying to figure it out, right? On the science end, on the background. And I love that type of research, process and circle. So I love that all of us are dedicated to that. So I'm going to end things now because I know we have a great discussion just because of time. But again, thank you all for coming. And we look forward to continue conversations over email. And I look forward to the research updates next month. And then if you have any speaker recommendations, I'm looking for someone for September. Okay, let me know. Thank you everyone for coming.
Thank you so much,
Thank you.
Caitlin. And great to
Bye.
see everyone. Yeah. Bye. Yeah.